Morning, everyone. My name is Denise Mananis. I am the Senior Director for External Affairs for St. John's Riverside Hospital, and I want to welcome you all to this webinar. Let me get a little bit of housekeeping done before we begin. First of all, I would like to thank Mike Matalal and Jason Latour from our IT department. They are our producers and they help us put these programs together for the community. And we really appreciate them because without them, we would be lost. Also, Nancy Anabi in my department, our community liaison, and Candace Cousins-Hopkins, who are the people who organize these programs and come up with the topics and work with our physicians to put this all together. So thank you very much to all of them. Also, I'd like to acknowledge our community partners, Sally Pinto, who is from the Yonkers NNORC, which is the Neighborhood Naturally Occurring Retirement Community that is under the umbrella of the Yonkers Office for the Aging and the Westchester Jewish Community Services. Also, Z. Baird, who is from the Yonkers Public Library, and as any of you who are from Yonkers know, they have 3 locations: the Riverfront, the Will, and the Crestwood Libraries. And we appreciate their participation in helping us spread the word on these programs. I'd like to just begin the program by introducing our wonderful speaker. Dr. Michael Ficazzola has graduated cum laude from New York University. He then received his medical degree from the State University of New York at Stony Brook School of Medicine, where he graduated with a distinction in research at the top of his class and as a member of the prestigious Alpha Omega Alpha Honor Society. Upon graduation, he completed his general surgery and urology training at New York University Medical Center under Chairman Dr. Herbert Lepore. Dr. Ficazzola has published extensively in the urologic literature, including peer-reviewed journals and book chapters on prostate cancer, minimally invasive treatments for kidney stone disease, and voiding dysfunction in both males and females. He has presented his abstract findings at national meetings, and his research has been recognized both nationally and internationally. In 2000, he was named a Pfizer Scholar, which is awarded to physicians who have advanced the science of urology and improved patient care. Dr. Ficazzola's practice consists of all aspects of urology, but he has particular expertise in minimally invasive urology, including laparoscopic urological procedures, minimally invasive procedures for kidney stones, and laser prostate procedures. We are so pleased at St. John's to claim Dr. Ficazzola as one of our physicians. And so we'd like to just say thank you so much for doing this with us today. And I'm going to turn it over to you, and I'm signing off for the moment.
Thank you for that wonderful introduction, Denise. September is designated Prostate Cancer Awareness Month since 2003, and it has been so by presidential proclamation. So as urologists, we take extra time out in December to discuss prostate cancer, and I like to take time out today to educate you all about this disease. Let's start with some basics. The prostate gland is found only in males and is responsible for making fluid that is part of semen. It lives just below the urinary bladder in front of the rectum. And the urethra, which is the tube that carries the urine out of the body through the penis, as well as semen, it exits and it centers through it exits through the penis, but it runs through the center of the prostate. And prostate cancer starts when cells in the prostate gland begin to grow out of control, similar to like any other cancer in any other organ in our body. Now, prostate cancer is the most common cancer in American men. 1 in 8 men will be diagnosed with prostate cancer in their lifetime. It is the second leading cause of cancer death in American men. 1 in 41 men will die with this disease. So despite advances in diagnosis, it's still a lethal disease. The good news is that when detected early, prostate cancer is almost always curable. With that in mind, let's talk about some risk factors. Risk factors include age. So after the age of 50, your risk for prostate cancer increases. Race, this is found more commonly in African American men. Geography, so if you live in North America, Europe, Australia, or the Caribbean islands, you're at increased risk of developing prostate cancer. Family history is important, so having a father or a brother more than doubles your risk of developing prostate cancer. And finally, genetic changes. So inherited gene changes such as, or also known as mutations, in certain genes are known to increase your risk of prostate cancer. And lastly, there's diet. Okay, so it is known that men who eat a diet that is high in dairy products tend to have an increased risk of developing prostate cancer. Most prostate cancers are found through screening. Early prostate cancer usually doesn't cause any symptoms, whereas more advanced prostate cancer does so, such as problems with urinating or with either pain or blood in the urine. Patients will often ask me, well, doc, what sort of symptoms should I be looking for if I have prostate cancer? And I often tell them that the most common symptom of prostate cancer is no symptom at all. And so that's why we have to be proactive in looking for this disease. That leads me to screening. So when should you be looking to have this tested? So it should be age 50 for most men. But if you're high risk, like African American male or family history, then at the age of 45, you should be starting. And the screening can include a digital rectal exam, which is when the doctor inserts a gloved finger inside the rectum to feel the prostate. And it will also include a blood test known as a PSA, or prostatic specific antigen. And this is a blood test, this is really a protein actually that's made by the prostate. It's not a perfect test because it's made by both benign cells and malignant cells, but it currently is the best test that we have to be able to detect this disease. So what happens if you have an abnormal digital rectal exam or PSA? Well, this then will lead to a prostate biopsy for a diagnosis. And if the biopsy is positive, then the aggressiveness of the cancer is determined by the pathology report. Let's go to treatment. When you look at prostate cancer treatment, there are several different options that are available for you. One option is active surveillance, and that means that you have a small amount of cancer and it's a low-grade cancer. And for those cancers, we tend to watch to determine if they haven't developed into anything significant. And most of those cancers will stay low-grade and never cause a problem. Some of them will go on to require treatment. So active surveillance is actually a form of treatment. The traditional treatment, radical prostatectomy, is a surgical procedure, and it traditionally had been done in open fashion, but more commonly in a robotic laparoscopic approach. The advantage to this approach is that there's less pain and less blood loss, and so there's an improved recovery as a result. Radiation is another treatment modality, and this can be done either by external beam radiation or radioactive seed implantation. Hormonal therapy is an additional treatment option, and this employs injection therapy, and the result of which is to decrease your body's testosterone production. And the reason why that's important is because in prostate cancer, testosterone is used as fuel for the cancer cells. And lastly, chemotherapy and immunotherapy are both options as well, but they're available currently for later stage cancers. New in treatment for prostate cancer is what's known as targeted therapy. And this involves using drugs to identify and attack cancer cells while doing little damage to normal cells. It's a form of precision medicine in that if you have a certain genetic mutation that is allowing a cancer to grow, then these drugs can be used to target those mutations and then render those mutations inactive. Some are currently available for prostate cancer for a late stage disease, and then there are others that are still in trial. So having gone over this brief overview of prostate cancer, I'll stop here to see if you have any questions about what I just reviewed.
I do have some questions that have come in from the audience. The first one is the various side effects. You talked about the different treatments, the medical, the pharmaceutical, the hormonal, and the surgical. can you go over a little bit of the side effects for each of those, and particularly surgical side effects, because in the past, we know that surgery has had side effects that do affect the quality of life for patients. And I was curious to know whether or not that situation has improved through new techniques and new tools.
Okay.
So, okay.
Yeah.
Sure. So let's review side effects of prostate surgery. So they fall into general side effects that are general to any type of surgery. So those include general side effects from anesthesia, things like bleeding or blood clot development or infection. And then there are those that are specific to prostate surgery, and those have traditionally been incontinence, erectile dysfunction, or loss of the ability to ejaculate. The robotic laparoscopic approach, although it leads to faster recovery, unfortunately has not significantly improved the incontinence or erectile dysfunction rates. Radiation side effects include bowel and urinary problems. Those are usually transient. And erectile dysfunction is also a side effect with radiation, and it's similar in terms of the rate of developing erectile dysfunction is similar in terms of surgery and radiation. There are side effects with hormonal therapy as well, and they include fatigue, loss of libido, or hot flashes. The important thing to note is that although there are side effects with any of these treatments, most of those side effects are treatable in one form or another.
Okay, thank you. Are there age limitations on any of those treatments?
No strict age limitations exist for any of the treatments. In general, with surgery, we tend to reserve that for patients who have a life expectancy of 10 years or more. But in general, there are no real age limitations.
All right, so in the literature now, I've been reading a lot about precision medicine. And is this something that patients can expect in the immediate future in the treatment for prostate cancer?
So precision medicine is medicine or treatment that's tailored to a specific patient. We touched on this a bit earlier, and it is available in prostate cancer for a later stage prostate cancer if you have a specific gene mutation. So currently in prostate cancer, that is only for patients who have what we call late stage castrate resistant disease. That is cancer that no longer responds to hormonal treatment. And in these patients, if they test positive for a specific gene like BRCA2, then certain medications known as PARP inhibitors can be used in those patients to render those genetic mutations inactive and therefore kill the cancer cells.
So that actually brings me to the next question, because you've sort of answered some questions that allude to this, but is prostate cancer hereditary? Does it come from genes from your mother, from your father? How does that work?
Inherited genetic mutations in prostate cancer are responsible for 5 to 10% of this disease, and it can come from either the mother or the father. In fact, there are other prostate cancers that share. There are other cancers that share similar genetic alterations as do the ones in prostate cancer. And these are cancers that are either ovarian cancers or pancreatic cancers. And again, those genes could come from either your mother or your father.
So there's a question in our chat. What happens after you test positive for the gene?
It's important to note that if you test positive for the gene, it does not guarantee that you will develop prostate cancer, or for that matter, any of these other cancers that are associated with these genetic mutations. But it does put you at increased risk. So if you do test positive, you're going to be monitored even closer than the average person who's at less of a risk.
Another question from our audience: what is the likelihood of a patient in an active surveillance program eventually needing surgery? If that likelihood is high, is it better to get the surgery?
Most patients in an active surveillance protocol will not require treatment or surgery for that matter. And in fact, if we're very selective about putting patients in an active surveillance protocol in terms of just choosing the patients who are low-grade disease and low-volume disease, then most of them will not require treatment. So again, in those cases, we would not recommend surgery because there's a good chance you're not going to need it.
Another question for you, is prevention possible? And does, let's say, nutrition play a role, as in an anti-inflammatory diet?
Right. Prostate cancer prevention is not really possible because there are risk factors beyond our control, such as race, family history, age, that play a role. However, there are factors that are within our control, and there are certain studies that show keeping physically active is helpful, keep maintaining a healthy weight, eating a heart-healthy diet like lots of fruits and vegetables and whole grains, and avoiding processed meats, and limiting dairy. So these studies have shown that following this type of regimen will reduce your risk of developing prostate cancer.
The treatments that we had started talking about a little bit earlier, and there's a lot of advertising that goes on now about surgical treatment and how to avoid, the incontinence or the impotence issues that many men experience. And I'm not sure whether it's surgical or whether it is the radiation, the seeds, but which treatment is actually better and that doesn't cause those sorts of issues?
So let's talk about first the impotence issues. Be it surgery or radiation, the chance of developing impotence is equally the same. So in that regard, one treatment is not any better than the other in preventing erectile dysfunction. With regard to incontinence, this is not very common with radiation. There's a bit of incontinence potentially as a side effect with surgery. However, it is quite honestly, the significant incontinence is quite rare. So usually the incontinence you can develop with surgery is a mild form of incontinence that is a stress-induced incontinence, that is physical stress. When you go lift something heavy or play tennis, you may notice a few drops of urine into your underwear that you would have to wear a liner for. And I would say the chance of that happening is 10% or less with surgery.
Okay. Another question from our audience. Any known role that medications for erectile dysfunction, like, I can't say this, sildenafil, may contribute to risk?
Interesting question, but to date there's not been any study to suggest that medications such as sildenafil play any role.
Another question from our audience. If a person is 73 years old and has been diagnosed with prostate cancer, but the medical insurance has not authorized an MRI for 3 years, what can he do to get an MRI testing, which his doctor is recommending?
So in this case, I'm assuming that the patient's on an active surveillance protocol and they need the MRI for that purpose. It sometimes just helps getting someone from the insurance company on the line and explaining to them the patient's status, because it certainly is clinically indicated and approved for that reason. If there is still an issue with getting approval, at that point the recommendation would be to undergo another biopsy to see if the cancer has progressed at all.
Okay, thank you. Is there any other questions from our audience? Put your hand up or type in a question. No? Well, all right. I think that ends our program for the morning. Dr. Ficazzola, I want to thank you for enduring we do have another one. Is there a standard for PSA or Gleason score that you consider low or moderate?
With regard to Gleason score, a Gleason score of 6 would be considered low. Anything above that is moderate or severe. So people or patients who are in a active surveillance protocol will be those patients who have Gleason scores of 6. As far as a PSA is concerned, there really isn't an absolute cutoff for a PSA that's considered low risk, but in general, we consider PSAs less than 10.
Can you explain what the Gleason score is and how is that determined? Yeah.
So the Gleason score is the pathologic assessment of the tissue. It lets us know how aggressive the cancer cells are. So the higher the Gleason score, the more aggressive the cancer cells. And it's simply an assessment that the pathologist makes by looking at the tissue under a microscope.
Thank you. Anything else from our audience? Waiting to see if anything pops up. Last call, everybody. Okay. Oh, we just got a nice thank you from one of our audience members. So with that, Doctor, I really appreciate your patience with our technical issues today, and sharing your expertise with everyone has been, wonderful, and we really appreciate it. So thank you.
Thank you once again, Denise. And again, I just want to say that although very common and even lethal, the point here is that when detected early, prostate cancer is almost always curable. So please, to the audience, please go see your doctor and get tested.
Great. Thank you so much.
Okay, thank you.
And ladies and gentlemen, we have his office number if you're interested. You can always call our physician referral number as well. And remember that we do still offer telemedicine, virtual urgent care, and that is the number. If you have questions or you have concerns and have a concern about coming in for care.